Hi, my name is Marcia Snow and I'm a speech language pathologist with health-related home care. In this video today I'm going to talk a little bit about swallowing difficulties, also known as dysphagia. According to SwallowingDisorderFoundation.com, as high as 22% of the population over age 50 experience swallowing difficulty. Several studies have concluded that between 300 and 600,000 individuals in the United States are affected by swallowing disorders. Causes of these disorders in adults can be a result of damage to the central nervous system, such as stroke, brain injury, spinal cord injury, Parkinson's disease, multiple sclerosis, ALS or Lou Gehrig's disease, muscular dystrophy, cerebral palsy, or Alzheimer's disease. Other causes from problems that affect the head and neck, including cancer of the mouth, throat, or esophagus, and injury or surgery involving the head and neck. A speech pathologist involved in the diagnosis of management of oral and pharyngeal phase dysphagia will perform an assessment. The most common assessment begins with a clinical swallowing evaluation. During this evaluation, the speech pathologist will obtain an extensive medical history and discuss your symptoms that you're having with your swallowing trouble. We'll then look at the strength and movement of your muscles that are involved in swallowing, and we'll also observe you eating and drinking to see posture, behavior, and oral movements while you're eating and drinking. After the clinical bedside swallowing evaluation, a speech pathologist may recommend an instrumental assessment. The first of these is called a modified barium swallow study, which is performed in a radiology department. During this study, the patient eats and drinks food and liquid that has barium in it, and these are of various consistencies: thin, thick, solid foods, soft foods. Usually, this is conducted either independently by a speech therapist or with a speech pathologist and the physician. And as you are swallowing these things, the swallowing process is observed under X-ray. There is no preparation for this test. So if you are scheduled to have a modified barium swallow study, you can eat your breakfast before you go, you can eat before you go. There's no special preparation for that, and it takes less than about 30 minutes to complete. The speech therapist during this assessment looks at a set of modifications, including the size of the bolus or the bite or the sip that you've taken, the texture of what you're swallowing, and your positioning to best observe the swallowing structures in the oral phase, which is your mouth, the pharyngeal phase in your throat, and the laryngeal phase, which is the opening to your lungs. The upper esophageal stage is also observed. If you haven't viewed our video on the anatomy of swallowing, please do so. I think you'll be surprised how complicated the swallowing process is and how easily it can be compromised. A modified barium swallow study allows the speech pathologist to identify specific problems and to try various maneuvers and compensatory techniques. For example, we might have you put your chin down. We might have you turn your head one way or turn your head the other way to see if that helps improve your swallowing or the safety of your swallowing. We also might try different textures. We might have you hold your breath. We might have you cough after you swallow to see if that helps in protecting your airway. More helpful than a bedside swallowing evaluation, because a modified barium swallow study can also let you know, you can actually see if you aspirate, in other words, if things go down the wrong way into your lungs. It can also prevent trial and error treatment. If we do a modified barium swallow study, if we want to try certain things during the evaluation, we can tell whether they work or not, rather than just trying them and hope they're working during therapy. Another instrumental assessment is called an endoscopic assessment, or a FEES. With the endoscopic assessment, there is a lighted scope that is inserted through your nose, and the swallow can be viewed on a screen. This involves looking at the anatomy and the physiology of the pharynx and the larynx and certain aspects of the pharyngeal swallowing function. Okay, now here are some things that you may look for that could be possible signs and symptoms with yourself or with your loved ones. Things that you can look for include drooling. Is the patient drooling? That's an indication that the person is not managing their secretions well. They're not able to swallow their saliva. That's an indication that there's a swallowing problem. Food or liquid remaining in the oral cavity after the swallow. After they swallow, do you still see food in the corner of the side of their mouth? They don't realize it's there. Food and or liquids leak from the mouth or leak from the nose. That should not be happening. Complaints of food sticking in the throat, complaints of a fullness in the neck, complaints of pain when swallowing. If there is a wet or gurgly sounding voice during or after eating or drinking, and you didn't notice it before they started to eat. Coughing during or right after eating and drinking. Difficulty coordinating your breathing and swallowing. Oftentimes you'll see this with patients that have COPD or friends or family members that may have a tracheostomy or have any kind of a breathing problem if they're getting oxygen. Your swallowing and your breathing are coordinated together, and when one is having some issues, then it usually affects the other. Other things to look for is if you find that your loved one has recurring aspiration pneumonia or recurring respiratory infections, or you notice they spike a low-grade fever after a meal. If it takes extra effort or time needed to chew and swallow, if everybody else is finished eating and 30 minutes later they're still eating, changes in their eating habits, specifically if they avoid certain foods or liquids. Sometimes people with dementia don't have very good communication abilities. They can't tell you they're having trouble, but you'll notice that they're not eating these hard foods anymore, or they're not drinking thin liquids anymore. It could be because they're having problems with it, and they realize it, but they just can't express it. If they have significant weight loss, if they are dehydrated, they might not be taking in enough. Also, a sign if you notice that while a person, especially those that have dementia, if their eyes start to water or they start to sneeze when they eat or drink, and they weren't doing this prior to eating or drinking, that's a sign that they might have a silent aspiration where it's going in the wrong way, but they've lost that sensation where you and I would normally cough, but their body is reacting to it in another way. Their eyes start to water or they start to sneeze. The speech language therapist determines whether or not there's a need for swallowing therapy. And this depends on the cause of the problem, the symptoms, and the type of the swallowing problem. Decision making must take into account many factors about the individual's overall status. It might include information concerning the individual's health, their cognition, their mental ability, their social situation, their cultural values, their economic status, their motivation, and personal choice. Some people choose not to follow our recommendations. However, of primary concern for us is how the individual's health status can be maintained or maximized. It is always our goal for the patient to eat, but to eat safely. A speech therapist may recommend specific swallowing therapy, for example, exercises to improve muscle performance. We may recommend positions or strategies to help the efficiency of the swallow, or we may also recommend specific food and liquid textures that are easier or safer to swallow. We might say it's not safe for you to swallow thin liquids, but if you thicken your liquids a little bit, they go down slower, you can manage it better, and you don't aspirate. Or you have trouble with the oral phase in your mouth with chewing. It's harder for you to chew hard meats, steaks, things that are dry. So you should only have soft, smooth things, such as this. After the evaluation, family members and caregivers can help by asking the speech pathologist questions to understand the problem and what we've recommended for treatment. Please don't ever be afraid to ask questions. You can also help in assisting the speech therapist's treatment plan. You can help the person with their exercises, you can prepare the recommended textures of foods and liquids for them, and make sure that the recommendations for eating safely are being followed. You can also keep track of how much food or liquid is consumed in case the person's weight is at risk. Approximately 10 million Americans are evaluated each year for swallowing difficulties. Up to 25% of hospitalized patients and 30 to 40% of patients in nursing homes experience swallowing problems. Up to 65% of stroke patients have dysphagia. Our society often revolves around food and meals. How often, when you want to celebrate something, is it celebrated with a meal? Or with a cake? For people with dysphagia, life as you know it changes drastically. Dysphagia can cause depression, low self-esteem, and decreased socialization, and increased health risks such as aspiration pneumonia, malnutrition, weight loss, and dehydration. But there are things that can be done to help. If you or someone you know is having difficulty swallowing, please talk to your physician about having an evaluation from an SLP, Speech Language Pathologist, at Health Related Home Care. For further information on the subject, contact the American Speech Language Hearing Association at www.asha.org or call one of us. Thank you.